So hello, and thank you for the invite, Yelena and Nikos. um, it's a bit awkward to give this talk, especially with some specific people in this room. And yes, I'm talking for Maria, Kate, Anita, Christy, the real heroes behind this huge effort to end up with the right living donor. Um, I don't think it's going down. Good. So, why living donor transplantation, as we all know, is a treatment of choice for most patients with end-stage renal failure. It provides the optimum outcome in terms of graft and patient survival. Did I do that? Sorry.
If you just touch it somewhere else, it should go away.
Can I go back?
Yes, go back. Oh dear.
Provides the optimum outcome in terms of graft and patient survival, and very important for the pediatric people, it gives a better chance for a preemptive transplantation as opposed to the waiting time in the deceased donor transplant list, which is around 2 years, as we heard earlier. Um, Through the sharing scheme, it gives the option and the opportunity to some people to get a better quality or a better matched organ, and something that we're going to discuss in a bit. And for a small proportion of complex recipients, it actually offers the opportunity to be benefited from a better organ that they would probably never be offered something similar in the deceased donor waiting list. So, and having all this in mind, obviously we promote and we try to always prefer the living donor option. And these are the numbers of our transplants for the last 2 years. And you know the combined program served by guys, which involves Great Ormond Street patients and the patients at Evelina, is considered, I believe, the biggest pediatric program in the world. And as you can see, these are the numbers of the deceased donor transplants, which is actually also less than one-third of all the transplants, whereas two-thirds or so it comes from a living donors. There are different types of living donor transplantation, of living donation. So one is what we call the directed donation. That's the very common scenario, especially in the pediatric world, that one of the parents donates to their child, or in general, it can be emotionally related donation, which mostly in the adult context is like when husband and wife donate to each other. If we don't have a compatible donor, or if there is any other reason that we will discuss in a bit, then we enter the pair donor recipient pair in our national. I'm definitely doing something wrong
I
here.
think you're touching this.
You don't want me to touch it? Okay.
I think you're touching the keypad thing.
I won't touch anything, I promise.
Okay, right. Okay, so
So the pair would enter our national sharing kidney sharing scheme. And as Maria mentioned earlier, if it is two pairs, it's called a pair donation. If it is more than two pairs, it's called pool donation. And something that is going up and up the last few years is what it is the non-directed altruistic donation. A number of people, which I believe is more than 110 now in the UK, they have donated their kidney altruistically, either as a direct donation to a patient, or most often, and that's something really interesting, and maybe we can discuss it in another time, how a non-altruistic donor triggers the chain donation, which is something that can end up in benefited much more people than one-to-one. There is also the directed altruistic donation, and this is, again, I will have a lot of referrals to Maria's talk because there were some overlapping. So, first of all, there is a genetic relationship and no established emotional relationship. This is, for example, a cousin that you've never met, and suddenly they hear that you have a kidney problem and they come forward to donate to you, okay? And the other one is what Maria mentioned with a lot of social media campaigns lately, is donors that they have no relationship, if they never knew the recipient before it was found out about the renal failure of the recipient. I'll be very careful now, sir. Great. So, how we find the optimal donor for our child? Well, this is a big process, and it's not a linear process. It's a very dynamic process that can go back and forth. Okay, and as I said, the real heroes behind this, especially this initial part of the process, is our living donor coordinators, Maria, Jenny, in the Great Ormond Street side, Kate for Evelina, and you're too many guys. Anita and Christy are here. So, as soon as we know that the child heads towards the need of a kidney transplant, an initial discussion starts with the family. And this discussion is not only obviously in one meeting, but it happens again and again. And that leads to especially the transplant coordinators in the pediatric side to form like a very strong bond and know very well the families and the different dynamics within the family. And that helps hugely when the adult donor side team at GUYS gets involved. They have a huge feedback and very useful feedback from the pediatric team to say that, you know what, this is happening, this is not happening, this could work, this will not work. Okay? And this is part of the initial assessment. And once we identify a potential donor, and as it was mentioned earlier, the donor, they need to come forward, okay? So we cannot say, oh, my cousin wants to donate to my child. The donor needs to come forward. Then we have set up this 18-week process that we're hoping to have done the transplantation by that time. In the first 2 weeks, they are, in a way, again, part of kind of the preliminary process in order to, when the coordinators facilitate the initial discussions with all the potential donors, because as I said, it may not be one. And especially when it's not one, then we need to find the most appropriate one. And the most appropriate one is not necessarily the parent with the best match. It's not necessarily the grandmother who he really wants to donate the kidney. Okay, so we need to look in a more holistic approach, the whole picture. Because to give you an example, yeah, most of the mothers want to donate to their children, right? But most of the mothers are much, much better to you know, calm their children or make the child feel secure after the transplant. Therefore, you don't want the mother to be stuck in another hospital having had an operation and not have, you know, like the most appropriate support for the child afterwards. We say that we look in social, psychological, and medical risk factors. We will discuss about the medical factors. Regarding the social and psychological, other things that we look into is who brings more of the income in the house? Is it sustainable to have the transplant? Are there other siblings? And, you know, since if especially if one of the parents is in another hospital having had a major operation, are there enough people to look for the rest of the children? Or who is going to be in the hospital? So there are lots of factors that we put in the equation before we end up choosing the right living donor. But once this is done and we have found the one, there is again the initial medical and psychological and logistical process, which again is run by the main living donor coordinator. And as part of this process, we will perform the, we will check on the blood group compatibility, we will check on the HLA typing, mainly for the children who have had reasons to be sensitized in the past. We need to make sure that the donor understands the process that they're getting into. Obviously, we need to take a very detailed medical, social, family history, and check on a number of factors, including the BMI, the past medical history, the past surgical history. But what is the main focus of this initial collection of information is to make sure that there is not any hard stop that will tell us that this donor cannot proceed. And these hard stops, which actually are the contraindications for living donors, include when their kidney function is less than ideal, and there is a specific threshold that's been advised by the British Transplant Society of when we can and when we cannot proceed with donation. If there is any active malignancy, if the BMI is greater than 40, if there is a history of diabetes. In terms of virology, the hard stop is the positive for HIV and HLTV. And then if you have proteinuria above a certain level, I'm not going to comment on the proteinuria in a room full of nephrologists, okay? The blood pressure, if it is not controlled after using one or two agents, and obviously if the potential donor is found out that has one kidney, probably we won't take it out, although there are mothers that they ask both of their kidneys to be taken out when they are in this very unfortunate family that they have two children with renal failure. And then any psychiatric disorders, which obviously will be, if identified or if suspected, they will be referred further to a specialist to assess. Oops. So regarding the renal function, the initial assessment is based on a measurement of the serum creatinine, based on which we estimate the EGFR. People who are of Afro-Caribbean or African family origin, we need to adjust the EGFR, and the most accurate measurement is using the EDTA EGFR. And you see that table that I was mentioning before, that what is the threshold of EGFR according to age that we are allowed to start discussing about donation or not. Obviously, as the age progresses, renal function is one thing. There are more and more factors that we need to think of, including, is that really the kidney that we want to give to the child? But we have other solutions for that we're going to discuss further down. As part of our preliminary investigations, we need some kind of imaging of the kidneys. It can be ultrasound, can be an MRI. Most often it's a CT imaging. And if in that imaging it is found out that there is a discrepancy more than 10% in the size of the both kidneys, then we're obliged to do a function test, a split function, to see, using a DMSA, to see which kidney, if the kidneys are within they're like balance their function. And if it is so, we always go for the kidney with the less function. Yeah? So we leave the better kidney to the donor. So, very common question is a history of malignancy in the donor side an absolute contraindication? And the answer is no. There are specific types of cancer that, yes, they are probably a hard stop, like a melanoma, a renal cell carcinoma more than 3 centimeters, lung cancer, breast cancer, sarcoma, and the ones you can see on the list on the right. But there are types of cancer that did not exclude you as a donor. For example, if you had a colon cancer, Dukes A, and that was more than 5 years ago, and you're considered treated, you are probably can be considered as a donor. And equally, I mean, I'm not gonna, but you're going down the list, but like a renal cell carcinoma less than 3 centimeters, something that we do use in the deceased donor transplantation as well, by just excising it, or a history of stage 1 breast cancer. Anyway, what I want just to take home as a message is that a history of malignancy does not automatically make you not a potential donor. Obesity. So big discussion. So for anyone who is still considered overweight, BMI of 25 to 30, they can safely go ahead and donate. Okay. So the discussion is what we're doing above 30. And until recently, I think BMI of 30 was like a hard limit. Lately, we start to jingle a little bit. So let's say 30 to 35, we kind of discuss it. Of course, that includes to make clear to the potential donor that going through the operation with a higher BMI means definitely higher risk of wound-related um, complications, wound infection. It makes the operation harder, which means less ideal, and we know that it will not we know that most of the people with BMI, especially above 35, which we wouldn't do it at the moment, to be honest, they would have a prolonged hospital stay as a result of the operation. And that my last point here, although this is known for a number of obesity-related reasons, is that obesity increases morbidity, but does not increases mortality. So, but that's still a reason not to do it, according to me. Now, I don't know, we are about to pretty much establish in the next few years the use of the robot to doing the donor nephrectomy. I don't know if the introduction of the robot in a regular basis changes these dynamics, and maybe it makes it safer and with better results to do the donor nephrectomy in obese patients. Obviously, this is a purely technical and surgical way of seeing it, because having an operation to take a kidney out on an obese patient, obviously you need to think of the increased risk of developing diabetes and all the other potential renal failure issues. Age-wise, so currently we do not consider donors less than 18. The Human Tissue Act does not allow it for England. It does allow it for Scotland. It's above 16, but we wouldn't do it. And that's one side of the spectrum, the young donor. And if it was to be done, because in theory, someone who can consent above 16, legally speaking, could consent to donate the kidney. But at the moment, if it was to do something like that, as a bare minimum of the good clinical practice, we would definitely require the co-signature of the parents as well. The main issue with a very young donor is that there may be renal-related conditions that they have not been diagnosed yet, and they will be in the next few years. On the other side of the spectrum, the old donor is not an absolute contraindication again. Obviously, you need to make it safe, and you need to make sure that from a cardiopulmonary perspective, you're not about to harm a patient. As we all know, living donor transplantation goes against one of the basic principles as stated in the Hippocrates Oath, that first do not harm. So we do harm to start with by doing a major operation to any donor. Let's not do it worse, something like that. So, but as I said previously, grandparent want to donate to the child. Now the sharing scheme allows us to enter pairs based on the age difference, and in that way the child would get like a younger kidney, and the kidney from the grandparent would be directed to someone else. Virology-wise, as I said, the hard stop is only the HIV and HDLV. I find it very hard to imagine us choosing a donor with the history of hepatitis C or B, probably. I don't know if we get to that point. I have not been involved in such discussion. Maybe we can help with that. I mean, if it is deceased donor waiting list or a Hep C, a living donor, but I'm sure that would be very complicated discussions. We may have it in the future. If the potential donor is CMV positive and the child is CMV negative, obviously we need to counsel on, on the prophylaxis that we need to have and the extra risks that the child have. And I have an exclamation mark on EBV, and that's because EBV virus, first of all, most of the children are EBV negative, whereas most of the adults are EBV positive. And EBV has a very strong correlation with the development of PTLD, post-transplant lymphoma, and that's is something that should have like an important kind of part in the equation of choosing a donor. But let's say that we went through this initial part and we don't have a hard stop, and now we are moving forward down our protocol. And in a way, at that point, there are two types of donors. There are the straightforward donors that they're good to go ahead, and there are the more complicated ones. The more complicated ones most likely will need further intervention. They will may need a further even procedure in terms of like a cystoscopy, like a flexible cystoscopy, investigating any microscopic hematuria or so. The straightforward one, they would go down the line. They would have their imaging reviewed in our MDM, and hopefully they will get en route to get a date, provided that the potential recipient is ready and have their operation. Now, as I said, as part of this final collection of our data, we have a CT angiogram with abdominal KUB for all our donors, and that's something that we discuss in our weekly MDM, where we have radiologists, the coordinators are there, transplant surgeons, and occasionally nephrologists. I just put some random pictures from these meetings just to show that what we can find, we will definitely comment on the number of arteries of each kidney, okay? I mean, I have one with 3 arteries here, okay? Again, depends. Obviously, our hope and what we would love to have is single artery and single vein in both kidneys. And if that's the scenario, we would go for the left side. And the reason for that is that the left renal vein, having to go over the aorta all the way to the cava, is much longer, which make it much easier the implanting surgery. So if we have the option of a left kidney with single artery and single veins, that's out of discussion. Unfortunately, that's not always the case. Regarding the venous, multiple venous branches, as Nico said, it's very rarely an issue, if ever, to be honest, because you can easily ligate any extra veins and use the one remaining. A common finding, and that's in the picture in the lower right side, is that you see that the cava, it's kind of pressed by the aorta. It's what is called like the retro-aortic cava, where the arrow is. Other things we comment on is if we have a single or a duplicated ureter. You can see in the picture in the upper right part, on the left kidney, there are 2 ureters going down, and that's something that we would like probably to avoid. And, different cysts or other anomalies that can include like PUJ obstruction. You can find stones, and the stones is another discussion. If there are small stones, first of all, you need to run a metabolic investigation to the donor to make sure that there's not any background of creating more stones in the future. If it is a single small stone, we would take the kidney with the stone. We would leave the stone-free kidney to the donor. And quite often, we perform a back table ureteroscopy trying to remove the stone before we implant the kidney to the child. Okay. So size, Nikos mentioned it roughly. Should size be part of the equation? I mean, if it's like a huge dad and we have a tiny child, should that exclude the dad from being the donor? Our answer is usually that size is not the problem. If it is, our solution would be and meaning that you can always implant it. The problem is how to close the abdomen in a safe way and without putting any extra pressure to the lungs, and then Nadine will start saying, the thing that she doesn't like. So solution to that is obviously to use an biological mesh. We use biological mesh because this is not, promoting infection as any other of artificial material. And that's, actually that's 2 pieces of mesh closing the abdomen. The reason we have the hands here, and I noticed that Nikos actually probably I stole the picture from him, is that we say that the kidney is roughly the size of our fist. Okay, so that's how roughly you can estimate the size of the parent kidney, and you can compare it with the child abdomen. Now, what we have done in the past, although I don't think we have done it for some time now, but anyways, another solution we have when there are concerns regarding that if the kidney will fit, what's the ideal positioning, etc. What we've done, Nikos has done this, is to 3D print the abdomen of the child, and that's what you can see here, and 3D print, based on a CT scan, the kidney of the potential donor, and that allows us to play in a way, or try, or try to position the kidney in the abdomen and make it possible to imagine how you need to do it and if it is feasible. Now, some special issues in pediatric transplantation, and which also should be part of our equation, is the HLA mismatching. Why HLA is mismatching? Because the children will most likely need a second transplant down the line in their life. Even, we say that our expectations from a living donor kidney is around 25 years or so, hopefully a bit more, but nevertheless, it's very likely that the child will need a second kidney, and that's why we need the ideal HLA mismatch in order not to sensitize the child, which will make it harder further down the line. ABO incompatible transplantation, Maria mentioned it as well, is probably less trickier in children because they have lower titers. Nevertheless, there is very clear instructions that incompatible transplantation, ABO or HLA, needs to happen in centers that they do have an experience in doing that and they keep up their skill set. Very important, as we said, that the children need to be, so we need a good viral script of the adult, the potential donor, because we need to have the children vaccinated, and the crucial role of the EBV potential transmission to the child. Social aspect, I will go back to I'll just duplicate what I said 3 minutes ago. We need to put in the equation stuff like the relationship of the child with the parents. Can the child afford the specific parent to be away for the first post-op period? Can the family afford financially or so the whole story? Or what would be the ideal setup to make this already painful process as much as comfortable? Once we've done all that and we have our donor, and I will just leave you with that, that's where we show up suddenly, apart from the X-ray meeting, and we assess the donor, obviously to discuss the operation, discuss the risks, discuss anything that may have been missed in the previous process, which very rarely has. And that's the time that we have the independent assessment from the HTA, make sure that there's no money involved, make sure that there's not any blackmailing involved, and that may happen even within families. If the plan is to include the pair in the national sharing scheme, that's the time to register them, and the final cross match about a week before we finally get the date and the pair is admitted to the hospital and have the operation. And I think that's all from me at the moment. Thank you.
Thank you very much, George. You've covered everything very well. Thank you. Can I ask everybody who may have a question or a comment if you do things differently in your unit? Oh, thank you.
How often do you really think there's a big issue with the size mismatch between a small child and an adult? And I suppose my point is that in Leeds can't think of any occasion where we've had to use mesh or anything like that. Now, we don't do laparotomies, we do them all extraperitoneal, and we tuck them up right under the liver. And it looks weird at the end because you've got essentially a wound with nothing in it other than a ureter coming down. But if you plumb the kidney onto the cava and the common, which is what we tend to use, you can get to the aorta if you want to, and you create a pocket which is naturally there, and the kids, their tissues are so untouched by anything else, disease, anything. They're really delicate. They just creates this beautiful plane. You stick the kidney up under there. There's no bulge. There's no pressure on the abdominal wall. You can close it with no problem at all. And we do that routinely. I mean, there was one time we had there was this massive farmer, humongous. They came in to see me in the clinic, and I was like, "There's no way we're getting your kidney into your child." They had a huge cyst on it as well, and we couldn't get it in until we popped the cyst and plicated it. But then it went in fine. So even some really big male father donors can go into these. It was his daughter, very small, she's only 3 or 4. Have you tried sort of putting it anywhere else or doing a different sort of surgical approach rather than just having to put mesh on?
You mean as opposed to put it intra-abdominally?
Yeah, if you just
So if you want my personal opinion, I think Nikos agrees, or maybe not. But I know that a number of my colleagues is that I think the kidney is placed much better if you put it in an extraperitoneal approach, in that pocket you describe. And that's what we've been doing. And that limit of 20 kilograms, we actually, at the moment, is definitely about 15, but from 10 to 15, depends of who is the implanting surgeon. There's a good possibility that it will go for an extraperitoneal approach. And I 100% agree with you that it positions the kidney better. And I'm so much fan of this technique that that's how I do the adult side as well, because I always was thinking, why we struggle to position the kidney in an adult and not the child? So you just go further up. I don't know, Nikos, if you have a comment.
Yeah, I mean, very good point. Even though there's a paper from Niaz Ahmed some years back where he used mesh. But anyway, I've only intentionally put in once the mesh in advance before closing in a dwarf case. So normally you don't need to, but we were caught out once or twice where we closed, we did this, and it was compressed, or we had to open and put in, or a day or two later where there was high intra-abdominal pressure, reduced urine output, but it's very uncommon. Thank you.